Good morning, everyone, and you're very welcome to the launch of the impact of COVID-19 on people with an intellectual disability. And this is our first report from Wave 4 of IDS-TILDA, better known the Intellectual Disability Supplement to the Irish Longitudinal Study in Ageing. And hopefully it's a household name at this stage. My name is Professor Mary McCarran, and I'm the Principal Investigator of IDS-TILDA. And I would like to welcome you on this, the UN International Day of People with Disabilities. And the theme for 2020 is Not All Disabilities Are Visible. And while I hope that today we are helping to make the experiences of people aging with an intellectual disability during this COVID-19 pandemic very visible. So I really look forward to engaging with you during this morning. Just before we start, I want to do some housekeeping about the event. And for any of you who haven't attended an event like this before and you cannot be seen or heard by the panel, and if you have a question for the panel, if you can please just hit the question and answer box at the bottom of your screen and you can type in your question there. And if you're having any technical problems, or simply wish to say hello, as I said earlier, please use the chat function at the bottom of the screen and you can type in your greeting and we will see it. But please use the question and answer box for the questions. Today's event we will run to approximately 12:15 and we're going to begin with a short address from Minister Anne Rabbitte. And unfortunately, Minister Rabbitte unfortunately cannot be with us this morning due to an urgent issue that arose, but she has sent us a lovely recording. She has recorded her session. After that, I'm going to provide a brief overview of IDS-TILDA with presenting the COVID-19 findings from this particular wave. And then we have a wonderful panel discussion. And I'm delighted very pleased that we have Olivia O'Leary, and many of you indeed may hopefully be familiar with Olivia, a broadcaster, and I know that Olivia has been a household name to many of us, and we're really pleased that Olivia is doing this for us today. And then we will finish up our proceedings with some final thoughts, and at the end we have a song written by Viewpoint Group from Sunbeam House Services. And just before we start, I really do want to acknowledge the support of the Health Research Board and the Department of Health for the continuing and the support that they have given over many years to IDS-TILDA. It's now in its fourth wave, so over the past 13 years, we have learned so much, and we still have so much to discover about how people with an intellectual disability age and what are the key determinants of health and well-being. So to begin with, we're delighted to have an address from Minister Anne Rabbitte, TD, Minister for State with Responsibility for Disability of the Department of Health and the Department of Children, Equality, Disability, Integration and Youth. And as I mentioned earlier, due to competing engagements, the Minister cannot join us live, but has recorded this message for today's event.
Good morning, ladies and gentlemen, and I'm delighted to launch this IDS-TILDA report, which looks at the impact of COVID-19 on the health and well-being of older adults with an intellectual disability in Ireland. I congratulate Professor Mary McCarran and the entire IDS-TILDA team for tying in today's launch with the United Nations International Day of Disabled Persons. This day aims to focus attention on how well we are promoting the rights and well-being of persons with a disability. IDS-TILDA gives us the information we need to understand how to promote the well-being of adults who are aging with an intellectual disability. IDS-TILDA is the first study of its kind in Europe and the only one in the world with the ability to compare the aging experiences of people with an intellectual disability directly to the general population. This is invaluable data, points to our success, and also identifies obstacles still to be addressed in order to advance a more healthy, just and equitable society. The IDS-TILDA study has for several years been at the forefront of research on ageing and intellectual disability, recognised not only in Ireland but also internationally as leading the way in research about the lives of people with an intellectual disability. This year has been a particularly difficult and challenging year for us all, and especially for people with a disability and their families. The COVID-19 pandemic represents a threat to the health of people with intellectual disability. Many people with ID are heightened risk to infection or an increased risk of poor outcomes should they contract the disease. Although many people with ID live in the community, many live in long-term care settings which have been identified as high-risk living spaces for COVID-19 infection. Consequently, it's important to understand how this particular population is being affected by the pandemic and associated lockdown, and to what extent they are vulnerable to being more severely affected. The IDS-TILDA study has made an important contribution to our knowledge of the situation on the ground, particularly in terms of the safety and well-being of adults with ID. It's positive news that to date so few people were infected with COVID-19 in this population. For this, we can be very grateful to Intellectual Disability Services for their efforts to control the spread of the virus, and for the families and the staff following public health advice. I'm acutely aware of how much of a strain the pandemic has had on people with a disability across the country. Although very tough at times, the strength and the determination shown is admirable. These results highlight that the public health advice, while hard going at times, has meant that the virus can be controlled and people protected. Needless to say, COVID-19 has not gone away and still poses a threat to the health of people with intellectual disabilities. We must all continue to follow public health advice. The latest research from IDS-TILDA tells us that more than half of the participants said they felt stress or anxiety during the pandemic. I'm sure many, if not all of us, can identify with the fears and concerns many participants expressed, but it should be borne in the mind that these problems can be heightened for adults with ID. They are often more vulnerable and sometimes have less autonomy than the general population. Notwithstanding all of these challenges, participants also indicated that the lockdown was a time when they tried new activities and had opportunities for more rest, more time with staff, and they used technology more often to communicate. This demonstrates the resilience of people with ID and the flexibility of their friends and staff who live and work with people with ID. We should look for opportunities to support such activities, and in particular to ensure greater access to technology for people with intellectual disabilities. Nonetheless, I am concerned that family caregivers in particular were placed in a difficult position of having to provide care with so many difficulties in providing respite. As we work to address the latest spikes and surges of COVID-19, we must find ways to support family caregivers. IDS-TILDA is one of the world's richest datasets of well-being in adults with intellectual disability, and Ireland is a recognised world leader in the field of ageing and ID. The value of longitudinal data within IDS-TILDA has been particularly heightened during the pandemic, as we have both comprehensive data and data from previous waves to compare with. That is helping us better understand how COVID-19 has impacted upon and even changed people's lives. People with an intellectual disability should be given the same level of attention as the rest of the population in terms of how we plan and deliver services. It is also valuable that what we are learning about COVID-19 from people with intellectual disabilities has significant implications for the general population. I want to sincerely thank the participants who have taken part in the IDS-TILDA, as well as family members, service providers, staff who have helped with the research. The continued success of IDS-TILDA would not be possible without their and your commitments. This is also true for the continuing support of the Department of Health and the Health Research Board. Thank you again for your invitation to launch this report, and I look forward to hearing more about the findings of this project.
So thank you very much. Lovely greeting there from the Minister.
Good morning, ladies and gentlemen, and I'm delighted to launch.
Apologies about that. Okay, so thank you very much, Minister Rabbitte, and unfortunately the Minister couldn't be with us today, but has sent on a very nice greeting, and I really do want to thank the Minister and the Department for their continued and ongoing encouragement and support. I'm just going to move on now with a brief presentation on the impact of COVID-19 on people with an intellectual disability in Ireland, with evidence from Wave 4 of the Intellectual Disability Supplement to the Irish Longitudinal Study on Ageing. Many of you may be familiar with this map of the world, and all of those dots around the map are longitudinal studies that happened all over the world. And when Ireland was launching the longitudinal study on ageing here in the general population, TILDA, which has been led by my colleague, Professor Roseanne Kenny at Trinity, I was very concerned, along with other groups of people, and worked closely indeed with Professor Philip McCallion and other people to ensure that people with an intellectual disability were included, because none of these other countries at the time had included people with an intellectual disability in tandem with their generic ageing studies. And I felt that Ireland really needed to address that inequity. We were very well positioned to do a study of this nature in Ireland. And this is the map here of Ireland for those of you who are joining internationally, and you're very welcome. Because we in Ireland have what's called the National Intellectual Disability Database. And I really want to thank Sarah Craig at the Health Research Board, who worked very closely with us. And we were able to get permission to randomly select 10% of the intellectual disability population in Ireland over the age of 40 years. TILDA included people aged 50 and over. We wanted to include 40 because of premature aging in people with an intellectual disability. So we have a nationally representative sample and we're able to compare their aging to the general population. And this is the various reports. And today, really, we're looking at the impact of COVID-19 on people who are aging. And just the key objectives of IDS-TILDA are to understand the health characteristics of people aging with an intellectual disability, to examine the service needs and health service utilisation of people aging, to identify the disparities in the health status of adults with an intellectual disability as compared to the TILDA findings for the general population, and to support evidence-informed policies, practices and evaluation. There's a very broad conceptual framework which underpins IDS-TILDA, and as you can see, we're collecting data across a broad range of parameters. And this is extremely valuable and has been extremely valuable now to understand the impact of COVID-19 on a variety of different domains. When we started this study at the beginning, we needed to use the protocol that TILDA were using, but we also felt that there were probably unique issues for people with intellectual disability that the original protocol may not capture. So we held series of focus group interviews with people with intellectual disability throughout Ireland. At each wave, we continue with this to see, is there additional questions that need to be included to capture issues which are important in their lives. And their whole domain in relation to social domain was a domain that we added, which wasn't included in the TILDA protocol. And we also added a lot of areas around physical health, oral health, pain, falls, and objective measures of physical health, health assessment, which my colleague, Professor Ailish Burke, has done sterling work in running out a health assessment. Long before anyone understood perhaps the language that we're more now familiar with, like PPI, public patient engagement, we involved people with an intellectual disability from the very beginning. from the advertising of the study to the generation of ideas around it, designing the logo, ensuring that all our materials are easy read. So we had a very strong values framework which underpinned it. And I think the involvement of people with intellectual disability have really contributed to the success. They've been involved in every aspect, from the generation of questions right through to dissemination, training our field workers. And actually at this moment and this week, they're busy assisting us write the easy read report, which we will be putting up on our website over the next few days. And we have had over a 90% retention rate over the last 14 years. And I don't think this happened by accident. It happened because people with an intellectual disability in Ireland are completely engaged, as is the caregivers in this study. But we all know that in January 2020, the World Health Organization declared an outbreak of COVID-19 to be a public health emergency, and it was declared a pandemic on March the 11th, 2020. We know that just to summarize some of the issues around COVID-19, which I think are important for us to remember and poses particular risks. I think there are two particular aspects to COVID-19, and that is firstly, the increased risk of contacting COVID-19 and the increased risk of adverse outcomes should you get it. And those who we know are at increased risk of contracting COVID-19 are people who live in residential settings, and indeed this includes many people with intellectual disabilities, people with reduced capacity to understand and to adhere to health guidance, healthcare workers, and we know other occupations requiring close proximity. So as you can see, that people with an intellectual disability can be categorized as a group who are at increased risk of contracting COVID-19. We also know that there's increased risk of adverse infection outcomes, and that older age, people over 70, people with organ replacement, receiving cancer treatment, severe respiratory conditions like asthma, COPD, cardiovascular disease, diabetes, and obesity are all associated with an increased risk of poor outcomes should we contract the disease. And we know IDS-TILDA has really robust data over the last 14 years and many of these healthcare conditions. And we understood that things like diabetes, like cardiovascular disease, like dementia, like mental health problems were very high. I will speak as I move through this presentation in terms of age of risk of poor outcomes. In the general population, we're talking about age 70 and over, but for people with ID, we're looking at a much younger age. So some of the key findings from some of the international research, and there's volumes of research coming out, particularly in the general population, but also indeed increasing volumes of research coming out within the ID category as well. So this is a small an observational study here from Watkins and Adam in 2020. And they looked at mortality rates and reported that mortality rates per 100,000 of the population was 3 to 8 times higher for people with intellectual disability compared to the general population. And this was a Welsh study. And then Public Health England, they looked at a large cohort of people with intellectual disability who had died, over 950 people. And they reported that mortality was 6.3 times higher for people with intellectual disability than compared to the general population. And this was after they controlled for issues like age and sex. We also are concerned that people with ID have adverse outcomes at a younger age. So this study here is an observational study by Perdera. It's conducted from the UK and Ireland. There's a small number of people from Ireland where they looked at just the reported number of deaths, and the average age of death, the reported was 64 years. And then Public Health England again reported the highest percentage of deaths for people with intellectual disability was within the 55 to 64 age group. And this compared to 75 plus age group for the general population. So here again, you're looking at this younger age of death. And again, the LEADER programme in the UK reported that half of the general population COVID deaths were aged, in the general population were aged 85 years and over, and this compared to 4% of deaths in people with ID within that age category. And there's also been increasing concern, of course, and unique concern for people with Down syndrome. And we're all aware that there has been higher rates of mortality for people with Down syndrome during the 2009 H1N1 flu pandemic. And this has been cited really as setting a worrying precedent during the COVID-19 pandemic. And just to say that in Ireland, people have been identified as high risk for more severe outcomes, people with intellectual disability in general, but they haven't been categorised as extremely vulnerable. And we know that more recently in November in the UK, they have added people with Down syndrome over the age of 18 years into the list of clinically extremely vulnerable group. And there has been some concerns expressed in relation to that, because we really do need to understand the broader and the longer term impacts of being cocooning or shielding for prolonged period of time. But nonetheless, we do know that people with Down syndrome are a population that you know have many of the high risk factors that lead to poor outcomes in terms of high prevalence of things like cardiovascular disease, obesity, and we also know that there is, you know, autoimmune disorders and chronic immune dysregulation, and this very often associated with having a triple copy of chromosome 21. So this really, I suppose, puts people with Down syndrome at added risk. And these are really from two very large studies. Cliffordell, they reported a 4-fold increase of hospitalization and up to a 10-fold increased risk of death in people with Down syndrome after controlling for cardiovascular disease, pulmonary disease, and place of residence. And then Hullis et al., this is from the Trisomy 21 consortium, a large number of people followed up, over 1,000 deaths, and they reported an average age of death for people with Down syndrome as 51 years. So there is concern particularly for people with Down syndrome and for people with ID. So when it comes to the discussion around vaccinations and age, I think these are important issues for us to keep in mind. So what are the key findings from international research? And this is taken from Pauline Haslip's group, that mortality risk factors for COVID-19 in people with intellectual disability included things like cardiovascular and pulmonary diseases, obesity, diabetes, but epilepsy, and we know that epilepsy is much more common in people with ID than the general population, and we reported a prevalence in IDS-TILDA of about 30%, which is similar to what other international countries report. But having a pre-existing history of mental illness, dysphagia, dementia, male, moderate to severe profound ID have poor outcomes. Again, Down syndrome, group living, and age 40 years and over. An increased risk of infection was associated with mobility, mental illness, and group living. And Stryker et al., they are a recent report from the Netherlands, and they have followed a cohort, looked at the population there over up to the end of October. And they reported, I think it was 67 deaths who had died. They reported a mortality rate of 11% in people with a confirmed infection. And 83% of their population were living in group homes in the community, and 17% of those were living independently in apartments. So the international literature has identified increased anxiety and depression and other mental health impacts of COVID-19. And we see a lot of talk about this from the general population. And there's increased risk of mental health impact in those with pre-existing mental health problems. And IDS-TILDA Wave 3, we reported that 52% of people in the study reported a diagnosis of a mental health disorder, 32% reporting anxiety, 16% reporting depression, and 15% reporting mood swings. So Inclusion Ireland did a recent survey of the impact of day service closure during the lockdown, and they reported that 33% reported increased anxiety, 38% increase of behaviours of concern, 56% of people with ID reporting significant loneliness, but 30% also reported a positive experience. And Family Caregivers Ireland survey of the life of carers during lockdown. This is people who are supporting the family member in the family home. And they reported that for family carers, 63% expressed concerns about their own declining health and well-being, for declining health and well-being for the person they cared for. 60% of carers were concerned about their own health and well-being, and 56% were concerned about increasing behaviours that challenge and mental health problems for their family members. So in March, when the pandemic struck, we were actually in the middle of wave 4 data collection for IDS-TILDA, and this presented quite a challenge. And that was how we would complete the data, if we were going to complete it, what would be acceptable. But it also gave us an opportunity to try to understand what the impact of COVID-19 might have on older people with an intellectual disability in Ireland. And at that time when that happened, the team very much ramped up, giving support to services throughout the country, working closely with the HSE. We ran a series of webinars on key issues of concern and tried to bring the community together through the community centre, and this I think was important. But we decided that we needed to adapt our approach, and we worked closely with the Scientific Advisory Committee and the Steering Committee. To complete the main CAPA interviews by video or telephone. We had about 255 remaining interviews to complete. We needed to reaffirm consent by phone or video, and this was different to our consent that we had been granted on our ethical approvals. And we needed to include an additional COVID-19 survey with additional questions. And this was a body of work, and we applied to the National Research Ethics Committee, and we got ethical approval to complete the study remotely and to also include our COVID-19 questions. And that involved, of course, the retraining of all of our field workers, the pilot testing of how remote interviewing would work. And just to say that this was very successful indeed. So we completed 739 interviews. We were completed as part of Wave 4 with older people with an intellectual disability. We do a pre-interview questionnaire, and we have 728 of those returned. We were in the middle of the health fair, which Professor Ailish Burke and her team are running, and we had 260 assessments, very in-depth health assessments, physical health assessments completed. So that's quite a sizable number. Unfortunately, we have had to rest the health fair for this year because of risk to our participants, which always take precedent over anything else. We also have a family care study, and we have 74 family carers completed the caregiver survey, and we had 710 out of the 739 participants completed the COVID-19 survey. And I'm going to now talk to you a little bit about what we found. So just to give you a profile of the participants, the male and female gender were quite well represented. The majority of participants were in the 50 to 64 age group, but we had people in 65 and over, as well as the 40 to 50. We were in the process of refreshing our sample because after 10 years, those who were 40 to 50 had aged out. And when the pandemic struck, we were in the process of refreshing that cohort, and we still have more work to do there. All levels of intellectual disability were represented, with 41% within the moderate range of intellectual disability. We had all residence type were represented, with the largest number living in community group homes. We had 33% living still in residential care, which is still a sizable number, but this has absolutely switched from our earlier reports where we had more people living in residential care versus community. So that's positive. And just to look at the prevalence of chronic health conditions. So this is really important because we know that many of these chronic health conditions put people with an intellectual disability at risk of poorer outcomes should they contract COVID-19. So we've seen that 66.6% were overweight or obese. There was a high prevalence of cardiovascular disease, with over half the population having a history of cardiovascular disease. High cholesterol was quite high at 38%, epilepsy and hypertension, and a number of other related diseases which are associated with poor outcomes. In relation to testing and symptoms, and there was some concern at the beginning that people with an intellectual disability might not be able to tolerate the testing or the testing routine. So 62.4% of 443 people that we administered the survey to had a COVID test. And of these, 11 people tested positive for COVID-19, which is quite remarkable. So it was a very small number at the particular time. This was during wave 1 of the pandemic up to September. We also had 50% of people with Down syndrome were also tested for COVID-19, and nobody with Down syndrome tested positive. So of the full sample of 710 people that completed the COVID-19 survey, 71 people had COVID-19-like symptoms. 8 of these were hospitalized with COVID-like symptoms or a positive test. And as I said, there was no deaths related to COVID-19, which is very positive indeed. So services appeared, and people with ID appeared to manage this quite well. It's interesting to look at the 11 participants who tested positive, and their numbers are way too small to begin to do anything sophisticated in terms of predicting those more at risk or less at risk. But nonetheless, I think there is some interesting issues for us to see here. So again, we had more males tested positive, and this has been borne out in other international data in terms of people with ID. Most people were in the 50 to 64 age group, and again, this is similar to what has been reported internationally, and again differs from what we see in the general population. Most had moderate to severe profound ID, again similar to what other people are reporting. All lived in group settings. 9 of these, out of the 11 who tested positive, lived in a more residential type setting, and 2 lived in group homes. So it'll be interesting now with future, we really want to look at this population going forward. But again, you can see that people, the more larger settings, puts people at increased risk. The symptoms that people with ID presented with were fatigue in 6 people, fever and a cough. And 4 people who tested positive out of this 11 were asymptomatic. They had no symptoms. And 10 of the group out of the 11 had high risk chronic conditions, and 9 had mobility difficulties. And we know that these issues put people at risk of poor outcomes. And 3 people were hospitalized out of that 11, and none, as I said, died due to COVID infection. So it's just interesting, even though the numbers are small, just to give us an understanding of the symptoms that people are presenting with, and though the age groups that appear to be particularly at risk. And because of the increased concern, in particular in relation to people with Down syndrome, and just to recap, we had 139 people with Down syndrome, 52% were male, 47% female, and we had people mainly within the moderate intellectual disability range at 52%, but we also had people within the lower levels of intellectual disability, and 27% within the mild category. And again, we had 35% were in the age 40 to 50 category, and 61% age 50 to 64. And as you can see from this, we had very few people with Down syndrome in the age 65 and over. And this is because increased mortality for people with Down syndrome as they grow older. And again, the majority of this population were living in community group homes, 53%, with 24% living with family or independently, and 23% lived in residential settings. Again, just looking at the comparison between those with Down syndrome and those without Down syndrome in terms of chronic health conditions. Again, this was a population where there was, overweight and obesity was also a concern. Less cardiovascular disease, but still a significant number with cardiovascular disease, high cholesterol, and epilepsy was generally associated with new onset dementia in this population. And as you can see here, people with Down syndrome who were in the cohort had a much higher prevalence of dementia than did the non-Down syndrome population. So I think, and we all know that they're associated with poorer outcomes. And then just comparing those with Down syndrome, with and without Down syndrome for symptoms and outcomes, as I said, with COVID-like symptoms, they were not 13 people with Down syndrome presented with COVID-19 symptoms. And out of that group, 2 were hospitalized with COVID-like symptoms, but none tested positive. So we had nobody with Down syndrome who tested positive. In relation to movement and moving residents, what we found was that 55 participants moved residents during the crisis, 24 moved to isolate or as a precaution after a test, 11 moved to move back to the family home, 7 isolated following hospital discharge. And people were isolated even immediately at the very beginning of the pandemic, post-hospital discharge, which was something slightly different than what appeared to happen in the nursing home sector. So in relation to compliance with the guidance, I mean, really people have to be congratulated for the level of resilience and resolve that people with intellectual disability had and their caregivers who were supporting them. But almost 8 out of 10 people, or 78.7% of participants with COVID-like symptoms or a positive test, had a clear plan to self-isolate. And 61% were able to comply with the guidance, and a small number, 33%, were unable to comply. And those who were unable to comply were those who had a more severe to profound level of intellectual disability and were living in residential type settings. And looking at stress or anxiety in relation to COVID. So we were very successful on one hand in preventing people with ID contracting the virus, but it also had a knock-on effect in terms of mental health and mental well-being, with 55% reporting feelings of stress and anxiety during the COVID period. And it was interesting to look at the different issues for people. And we have Fidelma Flannery, who's doing a PhD looking at this with us in greater detail with Professor Fintan Sheeran. So you can see from this here that those living in a community group homes, the biggest source of stress for them was not seeing family. And this has been really challenging for people, and particularly as the pandemic has continued for longer than any of us wanted to, this has been a major issue. Those who are living independently or living with family, the biggest issue for them was not being able to do usual activities. And also that was their major issue. And not seeing friends and feeling lonely. So people living independently and with family reported more loneliness than did any of the other groups. But there was also good things about COVID reported. So 58% reported some positive aspects, with 42% reporting it was the time that learned new activities. This was the time for increased rest and relaxation, that things weren't as rushed, that they had more time with staff and better quality of time. And 14% reported learning how to use technology. And this is really great because across the 10 years of IDS-TILDA, each wave we have reported the low level of technology use for this population. So I think COVID-19 and the pandemic has brought a major shift in terms of the use of technology for all of us, but I'm really glad to see that people with intellectual disability were also included. And this was some of the things that people said about COVID, keeping people locked down, was people keeping safe, and this is what family and staff had to say. Some people lost some weight, other people talk about the COVID stone, and people felt it was more time to relax, to learn new skills, learn how to use technology, see and talking to my family on Zoom. People talked, I learned a lot, and physical health has been good during the lockdown. So there was, good things reported as well. So that just gives you a kind of an overview of what we found. So just to summarize, we found high rates of testing and low rates of infection among IDS-TILDA participants. No deaths were reported, no cases of COVID-19 in people with Down syndrome. And this was largely avoided the worst of COVID-19 compared to what happened in the general population, and particularly what happened in the nursing home sector. So people with ID and families followed strict public health guidelines. There was a very good response from services. Planning and adherence to guidance was very robust, and those plans in place for people to self-isolate and isolation zones and areas, and a real effort to reduce the footfall coming in and out of residential settings and the use of agency staff, etc. Living in smaller settings may have protected those at higher risk. And the positives identified were doing new things and a greater use of technology. But many felt stress and anxiety, and they were highest amongst those with pre-existing anxiety, and missing family and friends was a major issue. And I know many of us may have heard a lot of conversation and coining of the phrase a new normal, but I really think for all of us, this is nothing normal about a pandemic. And this is not normal, and indeed for many of us this is completely abnormal, and absolutely for people with an intellectual disability or those who are living in care, not being able to see their family, not being able to see their friends, not being able to give somebody a hug, not to be able to be present when somebody is at the end of their lives. This is not normal at any length. But we have some critical gaps in knowledge remain. We have reporting data here at one point in time at the end of the first COVID-19 wave. There's a need for additional COVID-19 follow-up research outside the regular IDS-TILDA waves to support time series analysis and to assess change over spikes and surges. So we really are hoping to go back out into the field early in the new year and looking for resource to try and do that. We need to look at what are the implications of a long COVID for people with ID. We hear a lot of talk about that in the general population. Many people with intellectual disability may not be able to report symptoms of continued fatigue and other debilitating symptoms that we know are very evident for many people who contract the infection. So we need to try and understand how we'll capture that. What are the implications of extended isolation on mental and indeed on physical health and frailty for people with ID because of reduced activity? Where will people with ID be positioned in priorities for vaccines? And we need to avoid, from the data that I've presented, indeed our colleagues internationally have presented, that chronological age and using the cutoff of over 70 or 75 will not be a useful marker. We need to use other genetic markers, particularly looking at those with Down syndrome who are at risk at a much earlier age, and age of death is much earlier. And we need to look and base this on comorbid risk factors. And there is great hope now, of course, because a new vaccine is almost here. And we need to test this and really closely monitor this in people with intellectual disability. There's still, we're relying on our friends, some of our colleagues at Trinity, particularly Kingston Mills and Professor Luke O'Neill, who we still really, I suppose, need to see the data on this. But many of these trials have not been done in people with intellectual disability. And we know that for people, and particularly people with Down syndrome, who may metabolize medications differently, particularly as they're older. So we need to make sure that these vaccines are very closely monitored, that yes, that people are afforded them and should be prioritized, but that they're also closely monitored with trials to look at this. So IDS-TILDA, with its longitudinal design, has been present and has provided key data to help to explain critical changes in people's lives as they grow older. The implementation, for example, of the congregated settings report, we have data before and after it, changes in day programming and the measure of key health changes and health indicators. And I think during the COVID-19 pandemic, IDS-TILDA has been able to provide answers that will assist in our understanding of additional risk and protective factors for people aging with an intellectual disability. And this is a group that I do want to introduce before I finish, from Sunbeam House Services, and we will be finishing at the end, where they have wrote a lovely song to lift our spirits, and the song is about we're all in this together, and at the end we will play that song. When the pandemic started, we held a series of webinars to deal with critical issues at the time in terms of infection control, end-of-life care, etc. But we also felt that this was going to be a Christmas like no other for people with an intellectual disability. And we worked very closely with services in this country. And we held a wonderful webinar on November on Saving Christmas. And I was just at a wonderful launch at Piedmont Health Services last night, where they have created an absolute wonderful Christmas wonderland. And I know that Stuart's Care Services is having a lighting extravaganza later on this afternoon. And most other services in Ireland have really responded to save Christmas and to create the spirit of Christmas that's just so important for people who are not able to be close or with family and friends, or are not able to visit shops or see the lights in other areas. So I really want to congratulate all services in Ireland who have submitted amazing ideas on what they're doing. And I want to congratulate as well Michael Foley and my own team at the Trinity Centre for Ageing and ID, who've created this wonderful advent calendar, and you get a tweet every day with something new, an event, a task, or something, a recipe, or something for you to do. So please keep tweeting those out. And today is International Day of People with Disabilities. So be kind to yourself and let's celebrate with a mug of hot chocolate. I really just want to thank my own team, particularly people who helped with this presentation, and particularly this data analysis. Dr. Ailish Burke, Professor Philip McCallion is here, Margaret High, Greta Lewis, Andrew Allen, and Gavin Dan and Michael, and Sarah Bowman, and all the other team members who have been right across the university, who have been so involved, and indeed many other universities. I really want to extend our grateful appreciation to our participants, to our families and carers, to the IDS-TILDA Steering Committee, the Scientific Committee, and to the advisors and advisory groups, and to people with ID themselves who are out there today helping to get the Easy Read report finished, and particularly our funders, the Department of Health and the Health Research Board in Ireland. And this is our website, and you can download this and all of our other reports and papers from the TCID website. They're the list of references which we have included if people want to look them up, and there are many more. So I just want to say thank you very much for listening, and I look forward now to handing over to Olivia O'Leary, a broadcaster, and who's going to moderate this session. So thank you, Olivia, and I'm going to hand over to you.
Thank you very much, Mary. And fascinating findings in that report for all of us, and such a strong message coming through about the difficulty of controlling something like COVID in a congregational setting, as if we didn't already have questions indeed about congregational settings. But anyway, to introduce our panel, who are going to talk about the findings of the report, we have with us Dr. Alison Harnett, who is the Acting Chief Executive Officer of the National Federation of Voluntary Service Providers. We have Professor Chris Hatton, the Department of Social Care and Social Work at Manchester Metropolitan University. We've got Professor Sean Kennelly, the Consultant Physician in Geriatric and Stroke Medicine at Tala University Hospital. We have Lisa Lavelle, Director of Nursing, Daughters of Charity Disability Support Service. We've got Professor Philip McCallion, co-investigator, IDS-TILDA, Professor and Director at the School of Social Work, Temple University, Philadelphia. And we have Ms. May-Lynn Yap, PPI contributor and IDS-TILDA Steering Committee member. So if we could start, Alison, with you to put a question to you about, from the perspective of service providers, how do the findings in the report compare with the experiences of Federation members generally during the pandemic?
Thanks, Olivia, and thanks to Mary and all of the team in IDS-TILDA for this really valuable data, because I think we're just empowered by the evidence that we're seeing. So I suppose the evidence from the IDS-TILDA compares very, very strongly with the what we would have experienced from the National Federation. I suppose just to give a kind of perspective, our federation represents and supports, we have 59 member organisations who between them support around 26,000 people with an intellectual disability in Ireland. So the majority of services provided by the state are provided by voluntary service providers on behalf of the HC. And within those 26,000, approximately 8,000 people in general are living in residential settings rather than in their family home or independently in the community. And about 6,000 of those are supported by our services. So if we just take the very top line data that thankfully nobody passed away within the data that Mary McCarran has mentioned, my understanding, and this is subject to confirmation in terms of very recent data, but I understand across all of the disability services, whether that's physical and sensory or our own intellectual disability services, that there was 14 people who passed away so far during the pandemic who have a disability and who were supported in residential settings. And that's in the context of 8,000 people. And that compares very favorably with the general population. So I think in that sense, I think that the statistics would be very closely matched by the experience of our members. And I suppose our members would share the view that there was a very balanced picture. On the one hand, I think the services recognised the risk very early, took very proactive and strong measures. They collaborated with an exceptional level of partnership with the HSC to develop guidance and policies that would guide how we would respond as service providers, both at a local and a national level. And then there were things that happened very quickly. So isolation centres were set up. And those isolation centres were set up with the cooperation of HICWA very quickly to register them, collaboration between our members so that maybe somebody within the area might be able to go to an isolation centre that was run by another organisation if they needed to. Staff put themselves, I suppose, intellectual disability services in Ireland are very much relationship based. People know the people that they support. Some of them have lifelong relationships with them, and staff members volunteered to put themselves at risk and be at the very start of the pandemic, we really probably had a more negative outlook than what has happened, and people volunteered without hesitation to put themselves in what they presumed were going to be very risky situations. In terms of PPE, I know some of our members are present on this call, and I've heard of situations before the pipeline happened where people were meeting each other in car parks and handing over gowns or other things that were needed where the pipeline wasn't in place. So I think the collaborative approach across HSC and the service providers, and I suppose the rigorous use, the sharing of resources. And I think that the webinars that the TCID organised really helped to build a sense of community and a sense of shared purpose. There was more than 1,000 people accessing some of those, and the guidance that was coming from the medical professionals who were involved and as the situation evolved. And on the other side, that balancing piece is really, really present. We know that this is very difficult for people at home who have missed their activities, whose families have really had a very difficult time. So I think that the data shared through the study really matches what we've found on the ground.
Okay, well, if we could go now to Professor Sean Kennelly, who is a geriatrician. Sean, in terms of the experience of the general older population in Ireland during the first 6 months of the pandemic, how do the findings of the report compare with the general population, general older population?
Is Sean there?
Thanks, Olivia, and thanks, Mary, for an excellent presentation. I suppose there's probably very little comparison with regards to the impact on the older population, in particular the frail older population, relative to the people who are living with supportive ID services. By and large, COVID-19 has been marked out as a very, as a virus that's really exposed the inequities in our health services and exposed very high risk areas. And it's, there's a few things that I think are very interesting to compare. I mean, traditionally, I would have been very much involved in supporting care in nursing homes, and during COVID would have had much more experience, supporting the care of people in intellectual disability facilities. And when you compare both groups, while there are some similarities with regards the level of care that some people needed and that close contact, which of course in the context of a viral infection is what you're trying to minimize, people's ability to self-isolate. What you saw in ID facilities and in ID services was a much better integration into our general healthcare system. And that really has, marked out as, the environments were better suited to manage a viral outbreak, and that supported living environments are far more the norm in ID services versus our older person services. They're smaller in scale than a lot of our older person services, which meant that once a virus started, it was very difficult to manage it. Staff infections were a massive issue in older persons nursing homes, whereas they were less of an issue and seemed to be better contained when they happened in ID services. And some of that is the modular environment that was there. And I think a key thing is the governance structures in our ID services, which actually ties in a little bit to the integration into the general health service, but the governance structures and how you had, the social, holistic and medical governance structure that was already in place, which for private nursing homes in particular was less evident. And it just meant the fleet of foot to respond to a very rapid epidemic was greater in that service than it was within the context of our nursing homes. Now, within the general, while there's an awful lot talked about the impact of COVID in older people, it has very much been in that frail older group largely. I mean, there has been exceptions at both ends. Community dwelling older people have actually managed quite well, and most have recovered thankfully when they have gotten COVID. So it is really that comparison between, if you like, ID services and particular residential care facilities for older people that we see a big distinction in outcomes.
Yeah. And Lisa Lavelle, Lisa, I suppose this raises a lot of questions, just listening there to Sean describing the fact that so many of the ID services were perhaps better tied in to the health service generally, that you were talking about smaller settings rather than big congregational settings. So maybe you would talk to us a bit about, the extent to which the success of the handling of COVID in the area of intellectual disability, to the extent to which it depended, number one, smaller settings, maybe better nursing care being better tied into the health service generally.
Absolutely, Olivia, and I take Sean's point there in relation to the residential services, and I think one of the things that...
Sorry, I should probably say for everybody again, which I should have at the beginning, that you're the Director of Nursing with the Daughters of Charity Disability Support Services, which is why you know so much about this. Yeah.
Thanks for that. Just in relation to what Sean had said there around residential service and older person services, I think in the disability services as a sector, in its totality, everybody came together and looked and shared collaboratively information and any challenges that we would have had. I think we were very quick as services to shut down our day and respite services, and we redeployed significant numbers of staff into the workforce. That reduced the footfall within the services, and it excluded the employment then of external staff such as relief and agency staff, which minimised the risk of community transmission within the service. So that was one of the responses that the disability services in general addressed. So I think the other things that we were very positive was in terms of working together, sharing ideas, putting systems and structures in place. we set up our own isolation areas. So we had a very quick response when somebody had a suspected or positive COVID, and they were quickly moved into that area. And we had a very skilled workforce. We trained up all of our staff in PPE, and there was huge input from infection control leads right across the service in terms of ensuring that we had IPC measures, very, very stringent IPC measures on the ground in each service area, so that we could ensure that the spread of infection from community was reduced and mitigated as far as practical. I think what we did also is that we reduced down our residential services into pods. So we reduced the footfall within that service as well into smaller areas, so that the risk of cross infection and transmission of infection across different residential houses was minimised also. The other area
where you had residential settings, you actually tackled the question of the ease of transmission by creating pods. Yeah.
Absolutely.
Yeah. And I just wish somebody from the Department of Health was here, Lisa, to hear what you have to say, you know, because I've listened to all the discussions about residential care and the danger that there was because of congregational settings, and you tackled it. I mean, it's a model in a way for the way it was tackled. Could I bring in Professor Philip McCallion here? Philip is the director of the School of Social Work, Temple University, Philadelphia, and also co-investigator of IDS-TILDA. Philip, can we compare the experience of COVID for people with ID in Ireland with the United States? Is there anything we can learn from one another?
I think there's always things we can learn from one another. One of the challenges in the US is which part of the US are you talking about? Because there were such differences in response. But I'm most familiar with the Northeast, you know, New York, Pennsylvania, New Jersey, Connecticut, which really is 4 states tried to work together. I think that what happened for them was that they were overwhelmed initially by very large onset of cases. And that meant then that, for example, PPE and things like that got very concentrated in the hospitals for very good reasons. Yet despite that, in those 4 states, at least on the data that's currently available, and I think we all have to be cautious about data, and I think that's why Professor McCarron's talking about we need to do more follow-up. We know a lot about what happened in the first wave. We don't know what's happening as well in terms of later. But despite all of those challenges, the rates of infection and the rates of death among people with ID in the US, at least in those 4 states, was actually quite low as well. But yet we're seeing reports from other countries of much higher rates. I think we still have a lot of questions about what's happening, but I think that at the end of the day, care is always about relationships, and the relationships within ID have been well developed over time. We have networks out in the community, we have networks of support, but I think the biggest challenge, which was also highlighted here, was, you know, one of the solutions that we all came up with was we restricted visiting of family and friends. And that did help keep infection down, but I think we've all paid a really big price for that. And I think that families have paid a very big price for that. And I think the individuals themselves have paid a very big price for that. And I think that in terms of cross-learning, we really do need to look at that in terms of, you know, to what extent did we do too much with the really best of intentions? And as we think about whether it's continued spikes here or future infections, how are we going to address that together in a very different way? And I think the growth in the use of technology has clearly been helpful, but I forget who said it, but, you know, a hug is hard to do on Zoom.
Yes, it is. My sister, my special needs sister, hasn't been home since last Christmas. And every time I went down to see her, this was her complaint. Well, anyway, we got the wonderful news this week that she is coming home for Christmas. Hooray. Great,
Excellent,
great
excellent.
Hugs all around. And if I could move to Professor Chris Hatton. Chris, Chris, of course, is from the Department of Social Care and Social Work at Manchester Metropolitan University. Chris, what do you think we could both learn from one another in terms of the UK and Ireland in terms of care during COVID-19 for those with an intellectual disability who are aging?
Thank you. I think the UK has a lot to learn from Ireland. I'm not sure there's that much to be learned the other way around, to be honest.
No, we love when you say things like that.
As in the US, I guess the UK is devolved. So there's been some quite different things happening across different parts of the UK, across England, Wales, Scotland, and Northern Ireland. So in terms of kind of different periods of lockdown in different places, different restrictions, and in some ways different responses. So I guess located in England, I guess what I know from England is probably what I know best. I think this is just such an amazing project, the IDS-TILDA project, to produce this in this amount of time. Such data on people's experiences throughout COVID, I think is really valuable. And we don't have anything like this in the UK. We're starting a project that hopefully we're having our first interview today that will hopefully track people's experiences in the UK. About 1,000 adults with learning disabilities and 500 families over the next year or so. But we're only at the start of the journey, and the existing infrastructure that the IDS-TILDA project has been essential in producing such brilliant information in such good time. So we don't have anything equivalent in information on people's experiences. What's happened, it's been left to disabled people's organisations to produce local surveys. They've been invaluable, and they're pointing, I think, to some similar aspects of experience in terms of some aspects of anxiety and stress, some aspects of feeling isolated, as Philip's talked about, but also some positive aspects, particularly in terms of tech. The kind of use of tech is a really big thing that's coming out across the board. And I think one of the things that people talk about in the UK is people with intellectual disabilities are really geared up with tech in a way they weren't, but sometimes to be able to talk to members of families, the family members also need to be geared up in terms of tech. So the people at the opposite end also might need some help and support with that. We don't have any information really in the UK about COVID infection rates for people with intellectual disabilities. I'd be amazed in terms of testing if anywhere near the proportion of people with intellectual disabilities have been tested for COVID compared to Ireland. The response in the UK was, I think, as Philip said, it was a sort of save the NHS response. It was all about saving, preserving intensive care capacity, and that had a number of potentially quite catastrophic consequences, I think, for people with intellectual disabilities in the UK. There was discrimination in the application of who would be triaged for kind of intensive treatment, so that people with intellectual disabilities would be somewhere down the list. There's a report out today in the UK about the blanket use of do not attempt resuscitation orders for people with intellectual disabilities in various places without going through the legal consultation process. We don't really have anything like isolation centres that have been used. We didn't have quarantine for people entering the country. There was a fixation on social care, meaning care homes for older people. So for most people with intellectual disabilities who aren't in care homes for older people, there's a real struggle to get personal protective equipment. There's a real struggle to get testing. And the structure of the way that care is organised in England means that many care workers and support workers are on very short-term or 0 hours contracts. So that means if people had symptoms of COVID, they were in a real dilemma as to whether to continue to come into work even though they were ill, because they couldn't afford to take that time off sick. So there are all sorts of structural factors in England that I think are important.
And the point you make about the emphasis on saving the NHS, saving the acute hospitals, saving the intensive care areas, we knew there were casualties. It actually had struck me until you said that one of the casualties would be people with ID.
Yes, and just, I guess, to finish off, one thing we do have a lot of information on in England, thanks mainly to the LEADER programme run by Pauline Heslop and colleagues in Bristol, is about people with intellectual disabilities who've died from COVID-19. And that's certainly, we're now getting information on weekly deaths of people. The estimate is probably around 1,200 people with intellectual disabilities in England have died so far from COVID-19 in England. In the first wave of the pandemic in England, there was really quite a big spike in deaths of people with intellectual disabilities from COVID-19. And that is the period where we get kind of rates of 3, 4, 6 times deaths of people with intellectual disabilities compared to other people. Over the summer, that went down to virtually zero. That's increased now, but not nearly to the extent it was now. So some of those very high differences in death rates we've seen from the first wave of the pandemic might not be quite as high this time round, although they will still be higher. So I think the UK has an awful lot to learn from the Irish experience.
Okay, and if I can turn now to Mei-Lin Yap, who is PPI contributor and IDS-TILDA steering committee member. Mei-Lin, what's been your personal experience of living through this pandemic period?
Well, so the current COVID-19 crisis has been difficult for everyone, and we have all been forced to adapt to the new normal. So many of us are lucky enough to be able to continue to work, have been working remotely for almost 9 months now, which brings its own challenges. Working remotely can be difficult for everyone, including employees with an intellectual disability. So as a member of the Irish Down Syndrome Sporting Organisation, I had been selected to compete in the World Down Syndrome Swimming Championships in Turkey, which was due to be held in April 2020. I was very busy training in the National Aquatic Centre at 6 a.m. before work, twice a week, and swimming with the Dublin Swimming Club after work. So all my training stopped and the world event was postponed. So I was also going out to IDS-TILDA whenever I was asked to be involved in the work that they do. Then in my spare time, spending time with my friends and going for walks with my dog, Murphy. So life during the COVID-19 pandemic. So now due to COVID-19, I am now working remotely. I have a routine and I'm trying to keep healthy and fit. I am enjoying being at home. I'm really enjoying it very much. I find having a routine is very helpful. And I love that I can spend more time doing everyday tasks, like helping my mum with the cooking, cleaning the house, baking, gardening, and walking my dog Murphy. And of course, enjoying watching Netflix.
Yeah.
I miss spending time with my brother and my future sister-in-law, which they are both living in Cork. Unfortunately, their August wedding has now been postponed. So for now, I feel very lucky to be able to connect with my family and by telephone and by Zoom. So I'm also noticing more than ever that the importance of friendships outside of work and the value of family, having friends and staying connected and feeling included is so important.
Yes.
So working remotely has its challenges. What I find challenging right now is using my laptop. Whereas normally in an office, I'd have 2 screens. This can be a bit of a challenge when I'm working on something. It has been a struggle to keep healthy and fit, making sure I have the right portion sizes and keeping an eye on the snacking.
Yes.
Which a lot of people are doing at the minute. I'm sure.
No banana bread, I would say.
Yes. So it has been very hard not having any face-to-face interaction.
Yeah.
And I find it...
With your friends particularly,
yes,
that you miss.
Yeah. And I find it very strange. So it's nice when I find... it's nice when I do have the interaction with my team by video or by Microsoft Teams. I also feel more included thanks to CPL Staying Connected campaign.
You're working with CPL, yes.
Yes, so I work for CPL recruitment agency.
Yeah.
So I'm enjoying all this scheduled virtual cafe, catch-ups, virtual lunches, step challenges on Xevo, which is a CPL wellness partner.
I'm very impressed. I would imagine that Murphy is probably one of the best walked dogs in the area by now, is he?
Yeah, you can kind of say that, yes. So when COVID-19 began, it has been a shock to me. I have adapted well, and I'm now in the right mindset to focus and deal with the situation in hand.
Okay, well, Maylin, thank you. I'm just going to turn back to Professor Sean Kennelly for a moment. And Sean, just to pick up on something that Chris Hatton mentioned, which is the feeling that the concentration on keeping the acute hospitals from being overrun, concentration on intensive care, that he feels in many ways it created a hierarchy in which people with intellectual disabilities perhaps were not high enough up the priority list. What do you think?
Yeah, I suppose I can't comment too much on the UK experience other than what I've read in the media, and then try and extrapolate it to what I saw firsthand here in the Irish context. So early on, I mean, I think one of the things when we're talking about COVID, even now, although it feels like such a long time, is to remember it's not been that long a time at all. It's really just the 9 to 10 months. And to try and put ourselves back to where we were back at the end of February and the start of March, and the fear that everybody had at that time. And, you know, I think it's become so normalized, this living with COVID now, that we sometimes forget just how much fear there was at that time and how little we knew about what was about to happen. And the panic that was really ripping through every health service that hadn't had it yet, when they were looking at what was happening in China and what was happening in Italy and how that was potentially going to unfold. We were looking at patients being managed in car parks and large trucks. So that fear, as you know, that set that scene, I think, probably triggered. You know, it's not something actually that clinicians who are generally, you know, anticipatory by nature, it's not something that they had dealt with before, and as such started trying to make plans for catastrophic events that they thought might unfold rather than actually stay within the presence as to what they were dealing, because we didn't know how quick, because the other fear was is that this could happen very quickly. Early on, I suppose in around the end of February, we started to see some literature coming out of the UK about frailty assessments and about how they were going to triage access to intensive care systems. And in Ireland, there was initially there was an adoption whereby we were looking to our UK partners and thinking, okay, this is something we need to start thinking of. But there was actually a very quick revision that happened in the Irish context, whereby there wasn't a national policy about who would or who wouldn't get access to intensive care. It was going to be a local site assessment, and that it was going to be a very dynamic assessment, whereby, like, if you take our own hospital, there was 3 or 4 physicians who were involved in the decision, and the decision was largely stacked on the basis of, well, why wouldn't you, rather than why would you? And that actual, when you start in that context, it meant that there was a greater accessibility. That said, at the early stages, when we look at, so there was never an issue with regards to transfers from residential care facilities and things like that. Within services, though, I think there was an automatic reaction, and there was an advice that went out about have discussions with people. And I think it did set a tone unintentionally around, an expectation of care and setting of a ceiling of care that was there in the first wave, which by the time we became familiar with the COVID virus actually hasn't been evident in the second wave. And I do think is responsible for some of the change, the changes in practices and the changes and the difference in mortality outcomes that we've seen in the second wave.
Okay, and just a quick question to you, and I'm going to throw it to everybody else as well, just to move on rather than to look back. We are in the wonderful situation now of looking next year at a vaccine and at the availability of a vaccine. In terms of the priority list as to who gets that vaccine, do you think it's very important that people with an intellectual disability, particularly older people with an intellectual disability, be very high up that priority list?
So our vulnerable groups have to be at the top of the list. Our vulnerable groups and healthcare workers. Healthcare workers, because of the risk they pose to vulnerable groups, have to be the two groups that are prioritized for the vaccine, and that includes very much people who are living with disability and intellectual disability. Just by its nature, as I said, I think COVID has really exposed that inequality within the health service and amongst individuals, and it goes even beyond just health, right the way to those social care needs and, and people who are isolated groups, even to those carers, which we haven't managed to talk too much about today, who have been, really living under significant strain. We need to be able to open up these services. We need to be able to open up respite services, day services, and things like that. That should be the motivation as much as actually trying to protect people who are at high risk of developing COVID, but the need to open up services for these, far more important than opening up pubs, are far more important than opening up an awful lot of the other things that we've talked about. That's why we need to prioritize vaccination to these areas.
Absolutely. Alison, can I go back to you on that same question? The vaccines are here. It's just a matter of time before they're rolled out. Where on that priority list should people with intellectual disabilities be?
I think I'd agree fully that we really need to get the services back open so that people who are missing their activities and families who have been very resilient but who have had a lot to deal with can have a little bit of normality return. I think there's two important things that I would maybe add to the conversation around vaccination, and one is that I think it's really important we prepare very understandable materials so that people with an intellectual disability can have an informed consent process, whereby they have really good, strong information in a format that they can understand, and that we prepare ourselves ahead of time so that when a vaccination becomes available and when hopefully people that we support are at the top of that priority list, that we are working with them so that they're empowered to make those decisions. And I think that the Assisted Decision Making Act and the HC consent policy are two important things for us to bear in mind, and in terms of just supporting people to exercise their will and preference, but in such a way that they have a really good understanding of the benefits of the vaccine and what might come from that. The second point I would make is that I suppose in the advocacy role that the National Federation has been involved in within the pandemic and the budgetary process of the political system, one of the key factors that we identified across our 59 organisations, we did a survey and there were 40 respondents, 40 of the organisations responded, and within that there were 1,250 primary carers over the age of 70 who care for a loved one in their family at home, and more than 400 of those are over the age of 80. And I suppose putting that evidence into the public domain really helped in the budgetary process for people to understand why it's really important to invest in disability services in the context of returning. So I think that the bringing together of people we support who have an intellectual disability and potentially carers who might also be in the vulnerable category. I think there's a double priority there that we really need to respond to.
Yeah, I know a few of the speakers have brought that point up, Alison, which is that people with an intellectual disability who are aging have, you know, older sisters like me and brothers, you know, their families are aging as well. So on things like vaccination, but also on things like use of technology, you know, we need to be up to scratch, and maybe we haven't been. Lisa Lavelle, can I go to you on that issue of vaccination and the importance of where people with intellectual disabilities are on that priority list?
Absolutely, Olivia, and I would certainly add to Sean's point as well, and that another consideration is that people live with very vulnerable people in small group homes as well. So I think it's really important that people with disabilities are not restricted in accessing the community by virtue of the fact that they share a living accommodation with people who have very high and complex needs. So I think it's really, really important from that perspective as well that they are afforded that opportunity, that it's made available to people who have disabilities, so that they can open up their visiting to the community as well without any concern or risk of coming back in and posing a risk of infection to individuals who they live, who have significant needs as well. So that is another factor as well that needs to be considered when the consideration is given at national level in relation to the vaccine.
Yeah. May-Lynn, I'm sorry to land this one on you, but do you mind telling me how you would feel about taking the vaccine? You can always say you're still thinking about it. Don't worry, don't let me tie you down if you don't want to answer that.
I think it would be important for me or the disability community to take the vaccine, because I feel like it would help us in so much. What's what I'm looking for? Will help us hugely, I would think, in keeping us safe and all these things. It would help in a way to get back to some sort of normality. Even taking the vaccine and everything dies down and everything's all well and we're all safe and all this, to get back to the new normal, and just get on with things, to get back to normal routines, you know, going out and seeing your friends, going to see your family, you know, at a way that we can connect.
Yeah, it's a route back to even if it's a new normal, at least it'll be some sort of a normal.
To even see faces, even to come together, you know, just to do stuff together, like go to meet up for coffee or doing the normal tasks that people would do on a daily basis, is a huge thing for a person like myself, or anyone else for that matter, would be a huge thing just to get back to some sort of normality.
It would. The joy of other people. Mary McCarran, can I just come back to you as we're coming to the end of our discussion? I'm not sure whether we have questions in from our online audience or not. But Mary, is there anything else you want to add to what we've heard?
I think it has been a great discussion, Olivia, and just enjoyed listening to it. I think, I mean, we have managed the pandemic very well in Ireland, I think, for people with intellectual disability, and I think we should congratulate and acknowledge the resilience and resolve that people had, both the people themselves and the staff and carers. But, you know, as we approach Christmas and as we approach discussions on the vaccine, I think it is really important that we, as Sean has said and others have said, we look at those who are most at risk in terms of multiple morbidity. I would caution against using a chronological age, and there's a lot of discussion in terms of the age cohorts, because as we can see from the data we presented, that people are at risk at a much younger age, and mortality for people with ID is high in the 40s and 50s. And particularly then there's added risk for some cohorts, like people with Down syndrome. But we need to monitor carefully that vaccine. It hasn't been tested, I don't think, in people with Down syndrome. and it hasn't been, and as I said in my presentation, you know, people are aging, and people are aging with Down syndrome. We need to exercise caution, and we need our own trials, and we need to monitor how they tolerate this vaccine, and particularly from the safety perspective. And we need to look at issues around long COVID. I'm interested for people who have got COVID with ID, who may not be able to express or state how they are feeling now or what their recovery is. We need very innovative ways to listen and to hear and to see that we really understand the true impact of the pandemic. But I think we're in a relatively good space, but we need to move it on, and we need to open up, and we need to make sure that people with ID are not restricted to any layer of additional measures in terms of lockdown that we wouldn't expect for ourselves.
Okay, well, that just remains for me then to thank our panel today, to be grateful that the many lines didn't fall down, and indeed to hand back to Professor Mary McCarran for her closing thoughts today.
Okay, so thank you very much, Olivia. I think we have had a great discussion. I really want to thank you for chairing this and being available to us today. I also want to thank Minister Rabbit for her good wishes. I think it's great to have such support. I really do want to thank our panel members, Dr. Alison Hartnett, Professor Chris Hatton, Professor Sean Kennelly, Lisa Lavelle, and Professor Philip McCallion. And last but not least, I really do want to thank Maylin Yap, Maylin, who's been a member of our scientific steering committee and a great support and a real champion of the work that we do at the Trinity Centre. And I want again to just acknowledge the Department of Health and the Health Research Board for their own support. And of course, my own team, which I mentioned earlier. I think we are at Christmas is approaching. There is a good sense of hope in the air. We've did a lot to save Christmas. I'm so delighted that your family member, Olivia, is able to get home and be with you for Christmas. I think that's what we all want to do and to feel. So this is a period of good hope. And I think COVID is still out there. It hasn't gone away. So we need to still be very cautious and exercise the public health measures in terms of social distancing, the cough etiquette, the washing our hands. And we need to make sure that we protect ID services from a further spike or a surge in January post Christmas. So I just want to say to everyone, to wish everyone a very happy and a very safe Christmas, and to thank everyone for their participation. So I think we will close it at that, and I'm going to leave it with a wonderful piece of music which has been created by service users from Sunbeam House Services to see us out this afternoon. So thank you, everyone. Thank you. And I think, Gavin, you're going to upload the music, so lovely. Thank you, Gavin.
Don't be afraid, I'll always be with you. When you feel down and upset, I'll always be with you. When you need someone to talk to, when you need someone to turn to, we're in this together. We're in this together. We're in this together. We're in this together. I know it's tough for you. Just keep your head down. With time and care, we can get through this. When you need someone to talk to, when you need someone to turn to, we're in this together. We're in this together. We're in this together. when you need someone to talk to, when you need someone to turn to. We're in this together. We're in this together. We're in this together. We're in this together. Together. We're in this together.